So with raw milk, I'll say like, do you eat raw meat? Like, do you eat raw pork or raw steak? And if you equate the raw milk to raw meat, okay, now I understand. That's why it's bad.
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, riding solo again without the one and only Dr. Ned Palmer, who's somewhere doing something fun in California, supposedly. I'm not sure if that's true or not. Never know with that Dr. Palmer. But what I can tell you for sure is that today we have a fascinating conversation with a cardiologist who is very well versed in understanding social media, how to communicate with patients, understanding preventative cardiology and preventative medicine, I think, which is a huge topic these days, as it has been and should have been for quite a long time. But we will dive into all sorts of topics that you guys are hearing about and would love to pick his brain on some of those. So let's hop right into our interview with our cardiology friend. Today on the podcast for Doctors by Doctors, we're joined by Dr. Derek Weyhrauch, who is a pediatric cardiologist and preventative cardiologist that shares a message about heart attack prevention on social media. Originally from south of Seattle, where he completed medical school at the University of Washington. He then completed his residency at the Mayo Clinic and then fellowship in Utah, where he began his preventative cardiology training and completed a postdoctoral fellowship with the AHA. An enthusiastic triathlete and endurance athlete, Dr. Weyhrauch has swum from Alcatraz to the mainland not once, but twice, which is I cannot wait to understand why later. But he also raced the Leadville 100 mountain bike race in Colorado, which is crazy. He completed several Ironman triathlons, with Ironman Chattanooga coming up actually right after this recording in the next couple of days. He is most proud, however, of his role as a husband and father to 2 little boys, as well as finishing the ultra marathon that is medical training. He's on today to tell us all about that journey. Dr. Weyhrauch, welcome to the podcast.
Glad to be here. Thanks for having me.
I can't resist starting with the obvious since I just talked about it, but can you tell us a little bit with your obsession with putting your body through lots of torture and endurance events and swimming from Alcatraz to the mainland? Explain that to us.
It's funny timing with me having an Ironman this weekend and that being a big part of my personality. You know, they joke, how do you tell there's a triathlete at a party? You don't, they tell you. So like many things, triathlon and being a physician can be time consuming or all consuming parts of your identity. But even I did my first Ironman in medical school 2 weeks before step 1, which anyone that's gone through medical training knows that is like the test that you hang your residency application on. It's a really big deal. But I feel like the stress and all that we go through with medical training, I've kind of thought about exercise and being outdoors as like an antidote for that. So with the bigger dose in medical training, there's a bigger dose of the antidote. And the first time I swam from Alcatraz, that was all kudos to my parents. My dad had a connection through his company with a sponsor role for the race. And so in Escape from Alcatraz, you go out to the island, jump off into the water right next to it from this really cool ferry. So it's this long drop into the water, swim into the mainland. And so I think I was 17 when I had the chance to do that first.
And then you did it again, right?
Yeah, just last year. And that's the challenge. I've really found it encouraging as part of my social media channel, getting a lot of messages from pre-meds or med students or people that have a loved one that's in medical training. And they say, hey, thank you for just sharing that you're a happy doctor. You know, thank you for sharing about some of these life experiences, because it can still be challenging, though. Last year was when I did Escape from Alcatraz again. So it was really cool to go back, you know, over 20 years later and be able to jump off into the same water. It felt a little bit colder this time. But even then, it was really interesting because I was jumping off into the bay off Alcatraz, and 24 hours later, in the other side of the country, in the East Coast US, I was driving into a rural, like, pediatric and preventive cardiology clinic, like 24 hours after jumping into the bay. So there is some time compression as a physician, but you can still really fit in some of those life experiences that I think enrich everything.
That's the tough part, is balancing it. And obviously with the family and medical training, it's even harder, but kudos to you for being able to find that. Can you walk us through a little bit about why you wound up in the preventative and pediatric cardiology space? Why did you choose this route?
Yeah, thank you. I think it's really interesting to think about how when you look at specialty selection, we going into medical school, physicians only stay in the specialty we thought, I think about 25% of the time, if that's accurate. I didn't have preventive cardiology or pediatric cardiology on my radar going into medical school. But then when I went through our clerkships in third year doing our different rotations, different specialties, I found that even though I'd initially really liked a lot of the surgical fields, really liked the OR, 3 or 4 of my top 5 favorite things from medical school were surgical, but I ended up really liking cardiology. I think it was the combination of a specific fixable problem with the intellectual challenge. And there's just kind of a fun excitement about working with the heart. So I really liked adult cardiology. But then when I went into pediatrics, I found that for me, the kind of challenge of medical training was made more worthwhile working with a particularly rewarding patient population. And that can be found for different people in different areas. If they're an ER doc, it's those in crisis. If they're an internist, it might be a geriatric population. For me, it was pediatrics. I thought, oh, wow, peds is the most rewarding. But then when I went through pediatric cardiology training, the field itself is really research focused. And trying to be successful, I pursued that, and so I'm doing like funded investigation into the genomics and bioinformatics underlying congenital heart disease. But then what I really found was my lifestyle of using endurance sports, however effectively, right, to try to treat the strain and the mental stress that you get with being a physician. I really found the connection to those in preventive cardiology to be really rewarding. So there's a fun art and science to it when you talk about advanced lipid management, but then there's a really cool kind of coach-athlete relationship when you work patients through metabolic health, like getting started with healthy nutrition and fitness. And so I would really say it was kind of a natural evolution from my personal interests. And that also was reflected by my mentorship too.
Then you kind of started to bring your message to social media. And I don't know if that was a plan or it just kind of accidentally happened or what, but I'm very interested to have an understanding of how you wound up there. Was that just an accident?
It was a little bit serendipitous, yeah. So for whatever my personal style might be, this is how I tend to conduct myself in like research meetings and leadership meetings too. So for those that wouldn't know, as a cardiologist or peds or preventive cardiologist, you're part of a heart center. So you're really combined with pediatrics and ICU and cardiothoracic surgery. So cardiology and CT surgery work really closely, and you have a head cardiologist and a head CT surgeon. We had our annual faculty evaluation with my heart center, and this internationally renowned, just incredibly prestigious cardiologist who was our head executive cardiologist, Andrew Reddington. He met with me and he said, you should do social media. And I hadn't really had that suggested before. You know about it. You see physicians that post just as a standard user, but I hadn't thought of that for myself. And then it was really interesting. He said, yeah, I thought you have the personal style or an approach that people might engage with. So I created an account, but I only posted when I was at a conference or, just a couple times per year. And then almost exactly 1 year ago, I thought, okay, I have about 100 followers, all of which I was very grateful for, right? And so I said, okay, if you're going to do this, commit to doing it well. I had seen some of the content about posting regularly and learning from what works and just kind of evolving your approach. So I had 100 followers. I said, okay, I'm going to try to post almost every day for a year. And I hope by a year from now, I'll have 1,000 followers just to have a goal, And then maybe by 2 years from now, I could have 10,000. And then I was really surprised to see it grow much faster than expected, faster even maybe than I would have wanted to, because what I pride myself on isn't any kind of attempt to be any kind of influencer, but actually a physician, like kind of educating through social media, not anyone that would style themselves as an influencer or like a content creator. I really just am a physician making videos, but happily that led to me connecting with you and the team, and really great experiences over the past year.
That's awesome. Well, let me ask you this. Speaking of social media and where we are in our society health-wise today, a lot of news and tips get thrown around a lot. I'm curious, is there a health tip that you've seen go viral online that you'd wish just would disappear forever from the internet, if there is one?
Yeah, every time I go online, I really feel like if you ask me why I'm posting on social media, the number one reason is that every single week I meet a new family that had someone die or have a serious event that was a heart attack or stroke that was completely preventable in like their 30s, 40s, or 50s. Just every single week. And so that is my primary motivator. But then as a user, just as someone who enjoys like participating in watching social content, I see misinformation all the time. And so I think because I'm particularly sensitive to what I do, I just have these really powerful, in the worst possible way, stories about children that were harmed through unsafe practices. And that could be complacency regarding vaccine preventable diseases and concern about the vaccines that can protect children against them. If I had to pick one, I think the vaccine hesitancy into vaccine skepticism into an anti-vaccine hostility would have to be number one. But then, interestingly, I've seen a lot of conspiratorial thinking about cholesterol and statins. And so then within my niche, that's kind of particularly appropriate. But it was pretty funny. I had a patient last week in clinic, and a young woman and then her mom were there. And the mom, who's older, had just been advised to take a statin, but she was worried about the association she had heard about with dementia, which is unfounded. There's no actual correlation between statins and dementia. So then I said, "Oh, I'm so glad you mentioned that." And so this is an example of how I approach that. Because I see all this misinformation, you could call it out, you could rail against it, you could malign the people that spread it. But I've found that it's, I hope, more effective to teach people in an engaging way, and that protects them against misinformation if they understand it. So I told this kind of woman who was concerned about statins, I said, "Oh, that's interesting. So I can reassure you, there's no link between statins and dementia. But interestingly, statins protect you against vascular dementia by protecting blood flow to your brain. So they protect against one part of that. But a lot of these people that spread misinformation about cholesterol don't know that the brain makes its own cholesterol. It's behind the blood-brain barrier, and it makes its own." She's like, "Oh." I said, "Yeah, even better. The cells all make their own cholesterol. They have a mechanism to export it because they can make extra. So really, if we cut down the cholesterol in the blood that makes plaque, you're just cutting down the extra that's kind of circulating around that the brain doesn't even use." She was like, "Oh." I said, "But there is an association between cholesterol and dementia." She's like, "Ah?" I said, "Yeah, the statins, by preventing heart attacks or strokes, help you live long enough to get dementia." And then her daughter just burst out laughing. And she said, I like, "Thank you so much. You just put me completely at ease." So I think taking what is a firm but fair and fun approach to misinformation, you can teach people so they're better protected against it, but still address it instead of dismiss their concerns. So yeah, probably those two: vaccines and cholesterol statins.
What's interesting about that, I love that approach, by the way, because I literally had that almost exact same conversation just yesterday with an adult patient on the cholesterol piece. But actually, it was a different spin that I don't hear as much, but it was more not against the statins, but more so that we actually need higher cholesterol. And that actually helps us prevent heart attacks. And there's a YouTube cardiologist has a bunch of videos out. I wasn't familiar with this particular physician, but it was, I just think, I'm trying to listen, trying to understand, have a conversation. Everybody out there is trying to learn and understand what's best for their health. And so having some grace there, but it reminded me of a little bit, and maybe I'm off here. You're the preventive cardiologist, so keep me on track. But it reminded me of reading about FDR and the presidential physician that basically advised that we actually needed high blood pressure for the blood pressure to get through the vasculature that had aged.
Right.
And then, of course, he died from stroke. And I didn't mention that in the conversation, but it was just interesting. This theory I wasn't as familiar with that actually seems like it's gaining steam of actually we need as high cholesterol as possible.
Yeah, there's two different basically misinformation philosophies about cholesterol that are really popular. Some people will self-select any individual study that has a sub-cohort analysis, or maybe there is a worse outcome with a really low cholesterol level. But then you can tell them, what if someone had diabetes, had already had a stroke, and so then they get started on medicines to make their cholesterol low, but they already had plaque built up, so then they have another stroke anyway. That would be someone that had a treated low cholesterol, but it was caught too late. And so I think the approach that I take, where really I'll have a 30 or even longer minute visit and spend basically the whole time educating about how this builds up, it becomes so intuitive to them as to why just extra droplets would build up plaque, just like if it snowed every day, would build up more snowbanks over time. And then you can teach them about how these individual particles make it worse, that really through education, you can still prevent that from taking hold, that low cholesterol is actually bad for you. And at the same time, you can teach them about how you wouldn't want to dismiss high cholesterol. And there's even really fascinating studies, like one that's really spread like wildfire, was the keto CTA trial that currently has some controversy around it, where individuals that had a belief that high cholesterol is not harmful if someone's otherwise lean and physically active with a low triglyceride, a high HDL, LDL wouldn't be harmful. And interestingly, in a trial, their initial findings, they had to hide the initial finding because they found that so much plaque built up in just 1 year of intentional high LDL that it seemed to be more than was mathematically possible.
Oh, wow.
Yeah, you can look to families, and oftentimes when they hear something from another person, it's so much easier to sow doubt than reassurance. But I can actually give them personal anecdotes from patients, and that I think is what seals better understanding. They don't care if I can quote a study. They don't care if I can quote society guidelines. Even my professional opinion could be nullified by some other seeming professional that's sowing misinformation. But if I can tell them the specifics about a family that benefited from a treatment, there's a lot of catharsis there.
Yes, isn't that interesting? Like, we as humans really do relate to other authentic interactions with human beings. And it's something we've talked about on this podcast, and I would love to hear your thoughts. But, the growing sentiment, especially from people outside of medicine, of, AI can do a lot of the stuff we do, which is true to a degree. But on the human to human interaction, there is so much value and so much care that actually is like happens during that, just like your anecdotal stories that you're telling families, that it's just a human to human connection, communicating information that's not like it's straight from an encyclopedia or I just think that it's interesting the amount of value and bedside manner and kind of the soft skills that is. Maybe I'm a Luddite.
I'll join you there.
There's a lot that is gained by just having another human being communicating information on medicine.
Yeah, and the AI part is interesting too. And it's also interesting because there's a lot of individuals on social media that will say leverage a doctoral degree, but not list their doctorate or their professional role. And so there can be this concern for almost like a masquerading role to seem like a physician, but they aren't. And I was actually, of all places, in church when they presented this really interesting, not dichotomy, but two different philosophies on counseling, where one, I wish I could remember the Greek words offhand, but one was basically knowledge from books. And that might be AI, that might be an alternative health professional that had a course, but then there's knowledge from experience, and like the knowledge and wisdom that I think comes from experience. And so then when you can tell families that if they've heard something different, has that person seen a heart attack in real life? Did they work in a hospital? Were they in the ICU at 2 a.m. like I was, like every third or fourth night for a month or a year at a time? So then when people realize, oh yeah, you can kind of validate through this crucible that physicians go through medical training, you can validate that perspective, and the false equivalency between two different narratives becomes a lot more clear when they realize, oh, this is how much experience that we have. And then beyond that, I'll often tell them, we're trained not to do this because I might have different values or comfort with different treatments than you will. But after they give me kind of their preference on a treatment plan, I can tell them, here's what I would do for myself or my own son. and then the catharsis that patients get, and it's completely candid. I'll tell them I don't see drug reps, I don't get money from pharmaceutical companies. I read studies, I see who funds the studies and make sure it's good science. If this was my son, I would do this. And then typically they're sold. And I really mean it, right? It's only the exact same thing I would do for them that I do for one of my little boys.
I would never recommend something to you I wouldn't for my own family in the same situation. And I do mean that. And there's some times where I'm like, I'm actually not sure. Let's talk about what I would do in the situation and things I would consider. But I think it's it's just easier. It's just like the less you know about something, the more confident you are in it. And anyone who's not in healthcare, it's really easy to talk about how AI is replacing doctors. I rarely see doctors talking about it. Like if they do, it's more nuanced. The people who are talking about AI replacing doctors almost exclusively are not doctors and have never treated a patient ever. And because they don't understand all of the things we just said, that actually happens. It's not as though we get handed a sheet of paper with all of the objective data, and then we hand a sheet of paper back that gives the treatment, and then we walk away to the next one. Like that's actually not how care is delivered at all. And it's all the in between that, at least right now, our robots can't do and arguably shouldn't do.
I should do a post about that, like have it be in the, like year 1900. Like, oh, these books are coming out. They're going to replace doctors. And then the internet, like, let's say in the 1980s, 1990s, oh, the internet's good. We're not going to need doctors anymore. And then it's AI. We're not going to need doctors. So, I think an AI empowered physician or clinician of any type, in many ways, it can help you. But what I've loved, the two lines are AI won't replace doctors, but the doctors that use AI will likely supersede the ones that don't, right? And then two, we have so many barriers to making our healthcare system better. If we could use AI safety systems, if we could use AI administrative systems and billing systems, and that chart that I'll be sharing in a post where it shows the physician growth over time, and it's like here's flat and here's little physician growth, and then administrators is like Mount Everest next to a flat road. I think we could really impact in a positive way the healthcare landscape through AI making systems more efficient. And that gives physicians and clinicians more time at the bedside.
Speaking of technology, I'm curious your thoughts on wearables.
Yeah.
Are there any wearable devices you think have merit to be used on wider kind of population levels?
I've had a positive experience initially when some of the ECG enabled like smartwatches came out. We had so much concern about AFib in someone with zero risk factors for atrial fibrillation. It was just artifact that was misdiagnosed by the device. But then as the technology improved, it kind of became more like 20 false alarms out of 20 alarms, one might be positive. And people could catch short runs of SVT, supraventricular tachycardia, for those unfamiliar, or really impact their health in a positive way. Or we could find that if we send a patient home with a Holter to catch their arrhythmia, it doesn't catch something in the 3 or 7 days. But if they could buy a mobile device and then use that to spot check their own heart rhythm, we teach them how to do that, they can actually catch it. So we found it to be, I wouldn't say like a mainstream approach, but a potentially really positive adjunctive approach for heart evaluation. And then for me, I really think about how are you going to use the data? So if it's something where it's smart tech that could get them to sleep more and better by tracking their sleep, if it's one of the smart devices that can help check your sleep quality and your sleep duration. Families always asking me about nutrition and fitness, and I start each counseling session by default talking about sleep and stress. And so if it's a smartwatch that can get them to sleep better, that's amazing. If it leads them to get lost in the weeds because it's more data, but it's not quality data, then we don't tend to use it and go back to basics. So definitely a tool, but I wouldn't say that it replaces the things that we know how to do on our own.
It sounds like you get a lot of time with your patients on counseling, which is great. I heard you say 30 minutes. I don't know the last time I had 30 minutes at least scheduled. I might have spent 30 minutes in the room, but I would have loved 30 minutes to talk about some of these conversations with patients. So in those sessions, do you get asked a lot about seed oils and raw milk? And how do you respond to if people think they should start incorporating those, or lack of seed oils in their diet?
I'm really happy to say that that has not come up as often in my clinical practice, whereas I see social media replete with it. And so I'd say both of those are similar to how with cholesterol misinformation, you would want to have a understanding of the problem and then not a prepared reaction, but being prepared to talking about it. So, like for example, with raw milk, I can tell families I have personally cared for hospitalized children with hemolytic uremic syndrome. Here's what causes that. Here's how we prevent that happening, and how you wouldn't want that to happen. That there's no nutritional benefit to not pasteurizing, so you can teach them about why we do the things that we do, and that there's no benefit to not do them. And then beyond that, really I wonder if you made a pie chart of my counseling, if it would just all be analogies. If I just wouldn't say anything directly, but I just only like teach or counsel through analogies. So with raw milk, I'll say like, do you eat raw meat? Like, do you eat raw pork or raw steak? And if you equate the raw milk to raw meat, oh, okay, now I understand. That's why it's bad. You wouldn't eat roadkill from the side of the road. So you can make these analogies that associate it with something they understand is bad, connect it, and then address that too. And with seed oils, what I'll tell them is it's been really well studied, and I give them resources. There's a fantastic YouTube channel that I'll give my families all the time by this MD, PhD physician who seems to be completely objective, and he just runs through all these studies, just dozens of resources on seed oil. And so then if you use that approach similar to vaccines, I only want what's best for your child too. So here's the concern about these. If you look at the evidence, they're actually benign. It's not that they're good for you or bad for you, but they're benign. Here is what I recommend. And so then I would say that while it's not necessarily harmful to avoid seed oils, if you replace them with alternatives that we know are bad for you, it's net harm. At the same time, we could still encourage positives. Like in my home, we mostly use olive oil, and then we adjunct it with butter often, or random like variant seed oils, but mostly use olive oil. And here's why. And then when you teach families, they might be like, why don't we use olive oil for everything? I said, I did the math on how many olive oil trees you would need to replace seed oils with olive oil. And there's not enough space on earth where they can grow to like cultivate the land
Wow.
for how much oil we would need. So hence the reason to have these benign processed but health benign oils that are alternatives. And sometimes you can interject some humor where, I've never said this to a family, but I've thought it where I'm jealous, I'm envious of the people that are concerned about seed oils, because if your life is so comfortable, if you're so dialed in with your health and your finances and your stress, that your concern is about the like the health benefits or detractions of seed oils, you've made it. Like you've won. You are so locked in if that is one of your concerns. So I think by educating families again and sharing with them what you do, giving them resources, but also an opinion, you can keep them from, I would say, for more than anything, wasting their time.
What's the YouTube channel? Do you know it offhand? I'm curious.
So it's Nutrition Made Simple, and it's by Dr. Gil Carvalho. He's fantastic. And so I've been really excited to see his channel be successful because he just uses a data driven approach. I, as a physician and nutrition nerd, am completely engaged with his content, and he just goes through all sorts of studies and he cites them. And he's really candid about it. So I'll tell families, please don't work with a physician that is bought in on one thing, carnivore, the carnivore doctor, or like a certain kind of perspective being the truth for everyone, right? There's no Dr. Derek Weyhrauch single certified nutrition approach, because what works for me could be different for you, your family, your culture, the current stage for your health might be different than what you want to do long term. And hyper exclusive diets aren't often the best thing long term. And that's what I've liked about his channel too, because for example, with some of the data he's presented, if someone went not necessarily keto or carnivore, but if they went low carb, if you have salmon on mixed greens, that's a great low carb meal. Zero concerns for me. But if you use the low carb ethos to then justify guilt free, high saturated fat eating with like salami and cheese, oh no. And so that I really think it comes down to the nuance of execution where he presents it that way. And so here you can have a healthy low carb diet or an unhealthy low carb diet, but here's the positives and detractions. So I think a balanced evidence-based voice for me is like a beacon of light in the wilderness of what I see online in the nutrition space.
What do you think about buying supplements off of TikTok Shop?
That is a fantastic question. It's been really interesting. Whenever it was surprising for me to receive messages from different potential channel partners where they said, "Hey, we're interested in working with you. Here's what we'd ask you to endorse or recommend." And I've been messaged a number of times by supplement companies offering surprisingly lucrative amounts of money that I've universally declined. Because if someone asked me like, "Hey, supplements, do you recommend any?" There's a funny line, not to tie everything back to triathlon, but one guy from triathlon said for speed work, he said speed work is the frosting and you don't have the cake yet. Where it's like focus on the essentials, right? Okay, are you sleeping 7 or 8 hours a night, rested, don't need naps, high quality sleep? Are you proactively managing your stress? Are you eating in a whole foods, effective, calorie conscious way? And are you exercising every day? Okay, if you're doing all of those things consistently, if you add in some supplements, maybe like creatine, magnesium, melatonin, maybe those could empower your health a little bit. But if you don't, I mean, supplements for me aren't even the frosting. They're like the sprinkles that you put on top of the frosting. And so that I think a lot of people focus on supplements wanting a fix that they could take action for when really they don't protect their sleep and they have unmitigated stress and they're not exercising regularly and they're eating a lot of processed food. So that's where in my practice, I would love to talk about supplements, but because I have to talk through sleep, stress, nutrition, and fitness first, there's often so much room to even make progress in those essentials that I never get to the supplementals.
Never get to the sprinkles. No, that's a good. I love the analogy. That makes total sense. I'm thinking of just diets when I was a kid. What we were eating, what was fairly standard around my house and other kids' houses. Do you think that kids in this generation have healthier hearts than kids who grew up, say, in the 80s and 90s?
Oh no, I would say much more unhealthy. In fact, as an extension of that, I'm in a project right now looking at the amount of metabolic liver disease that we've discovered incidentally through preventive cardiology referral, just from insulin resistance and triglycerides and cholesterol. And when you look at it, the hard part is there's the American culture that can evolve toward some more sedentary activity. There's some climate challenges that many places have that others don't, like Colorado and Washington have a more affluent population and more temperate or manageable weather, whereas other places like Missouri and Alabama don't, right? And so the weather can be a factor too. The food culture in that area can be a factor as well, with like fast food predominance and higher calorie foods or certain cultural foods unique to that area. But when I look at it, I would worry that our children's heart health is much, much worse, and that we're going to have associated heart attacks with people being in their 60s and older, and that's going to become a phenomenon of more in the 30s in just a couple decades. Go back, oh yeah, you had a heart attack, oh, he's in his 30s, and it won't be unheard of. And when you look at processed foods, I had myself given my son, he actually asked for it, he rarely asked for a toast. So my son, who's in elementary school, he wanted toast. So I make his breakfast each day on school days. So I'm making him toast, but I'm in the habit now of checking nutrition labels. And we bought one of the fancy kinds of bread that makes you feel good about yourself, had actual nuts and seeds on the outside. This is legit quality whole grain breads. It's advertised as being so good for you. So as I'm getting his bread out, I look at the back and they add 4 grams of sugar to every individual slice of bread, which is the equivalent to me taking out a piece of bread and then sprinkling a crumbled Oreo on top of it and giving it to my son for breakfast. And you'd never know. 4 grams at every slice in Oreo. And this company maybe was health focused, but they got bought out by a food conglomerate in 2017. Because then I went and looked into it. And so then there you go. And so then I went to the grocery store because I was so curious about this. And I looked at 10 different kinds of health advertised bread before I gave up. because each of them had similar amounts of added sugar. And so I think that's the problem. Is it with a lot of my families, it's not that they're intentionally eating or drinking. They're not having cake every day, but what they don't realize is that a soda is the same sugar as two pieces of cake. And if they have a soda 3 times a week, that's like similar to eating cake every day, and they don't realize it. One of my families recently was in clinic, and they said, he eats really clean. I don't understand why his triglycerides are high. We don't eat that much sugar. I asked, okay, what'd you have for dinner last night? And they said, well, he had like pork chop, but with a ton of vegetables. He got full on the vegetables and mashed potatoes, but not too much. And I was like, oh, that's a great dinner. That's good. Oftentimes what I run into with families is sauces. So barbecue sauce has 2 Oreos worth of sugar per tablespoon. And they said he had barbecue sauce on his pork chop. And so there you go. It's not the intentional, it's the hidden. And I think unless we make some really significant changes with keeping these companies accountable for the ultra processed food environment that we now live in, a TED Talk once said that we're all fish in bad water. And like that makes sense. You try to protect, you can try to keep your children healthy, but we're in this society that is so much high calorie, hyper palatable processed foods that it just kind of afflicts itself upon us almost.
What's the one health policy change we could enact today that would have the single biggest impact on children's heart health?
No added sugar. Like from thousands and thousands of patient environments. I once spent that 30 straight minutes with this teenager talking through every aspect of health, right? Again, sleep, stress, nutrition, fitness, all these things. And hilariously, no one's ever done this. Hilariously, he almost aggressively said, that was too much. Give me one thing. And I said, no liquid sugars immediately. So I thought he thought that he would throw me off by challenging me that way. He said, that's too much. Give me one thing to do. And I said, no liquid sugars immediately. Because I think the problem is, even if children try to eat healthy, my wife and I will eat a mostly whole foods based diet, but we still have random snacks and treats. And so she had bought these strawberry coated pretzels, and I'm eating whole foods. I had strawberries in the fridge. I tried one, and you would have thought it was some kind of recreational substance. To like sweet and salt and the calorie density of it, it's just, that's going to win every time. And then when children, if you try to get them to eat vegetables, it's like asking them to eat grass. Their palates are so corrupted by this easily processed, hyper palatable, sugary, enriched, calorie dense food that they reject healthy foods. They don't like the texture anymore. It's the texture of an orange. And so I really think whatever we could do to combat the ultra processed food environment, number one for me being added sugar, and then encourage more physical activity, those would be my 2. Any way that we can make those happen.
If you had unlimited research funding, blank check, unlimited research funding, what would you study?
I am obsessed with the energy balance. I think working with, again, like thousands of families, every time it's been successful, there's been a paradigm shift. They don't do anything the same, but it's always the same. They generally eat healthier, they generally stop eating bad, and they're generally more active. So if it would be either the psychology of accomplishing that or the practical elements of how do we accomplish energy balance, what I'd love to do is take a cohort of patients, and I'm working through ways of like finding funding for this, because it has to be benevolent, where a lot of my families, they want to, but they don't have access to it. And so if I could give them the provision of like a walking pad or a treadmill to be able to walk like 30 minutes, 3% incline, 3 miles per hour every day. And then even some kind of like wireless headphone, and then they could use their phone, and then they could have that activity each day. I really think an approach where we could achieve that energy balance, to borrow from the Ironman Hawaii course, our World Championships course, there's this area called the Energy Lab. That's the most like difficult part of the run course. And so taking that Energy Lab focus to like energy balance, using it to try to capture that for individual families, I think easily would be my number one thing. How can you get them more active, and how can you get their diets healthier?
I think you are the maybe second or third ultra athlete. That's not, I'm endurance athlete. I don't even know the right terms. That's how not much of an ultra athlete I am. on this podcast. It's like a weird, and I would say I'm surprised that both of them, you and Dr. Martin, are both pediatricians.
Was that Dr. Tommy Martin?
Yeah, Tommy Martin. Do you think that peds has the highest percentage of endurance athletes of any specialty? I would think it'd be like emergency medicine.
I would have to look into that. I am really good friends with several emergency doctors because they mountain bike and they rock climb. They're always down for a good time. So if we're not the most outdoorsy, maybe there is something about that, just the personalities that are attracted to it, maybe the challenge and just the rewarding nature of the work despite the challenge, and that's pretty fun too, because with Dr. Martin, I was just messaging with him. That's a great example of someone that I was able to connect with through social media, just like yourself. And so I'll be supporting his Cape Epic challenge. And like, how interesting to have me as someone with 100 followers years ago, just a random physician with my own account. And now I have the privilege of Dr. Martin following my account. And I'm messaging with him. And like, he'll be like, "Hey, my friend." And I'm like, "We are the best friends that have never met in real life." Because I just messaged him, that I'm here for an Ironman. And I was going to make a joke. With his permission, I'll probably post about it, where I had seen he'd recently done a half Ironman in concert with the Ironman Foundation. And so then I saw that post. I thought, oh, this is interesting. And I was like, I'm a physician. I'm a pretty competitive triathlete for like my like age or metrics. But so I thought, oh, okay, let's see how he does. Blows me out of the water. He is so fast. He's so fit. He's the nicest guy. And so it's kind of funny where I joked that if I didn't ever lick the Pokemon when I was younger, but like if I was a Pokemon, like the next higher up Pokemon of me would be Dr. Martin, just a super inspirational.
He's also, I would guess, you probably don't use as many exclamation points as he does on his text messages. If he hears this, he'll be laughing.
Those are an addiction. Yeah, I try to keep it to one per message, and then I'll go back and I'll erase them and rephrase and replace them with periods.
Even more exclamation points, like one after the other. It's aggressive, but I know he means it. It's authentic energy.
That's his speech coming through in text.
That's exactly right. I'd like to think he's doing actually speech to text and just yelling in it, and it's translating it for him 5 exclamation points after each sentence. I don't know.
It's got to be the case.
All right, we got some rapid fire statements. So I will say a statement, and I will ask you if you think it's true or if it's false. And I'd love to hear your opinions on it. All right. I say rapid fire, but almost always it's not rapid. It's actually the opposite. But let's take the first one as an example. All right. First, true and false statement. We would be better off making medical school 3 years instead of 4.
False.
Tell me why.
I think about that. There's a physician shortage, and we need to address it. The 4th year is considered a more relaxed year with non-essential clerkships that could otherwise allow us to condense medical school into 1 or 1.5 years of didactics and then 1.5 years of clinical clerkships. I think the problem with that is that we have residency and fellowship, and the amount of time that our training takes is pretty impressive. So when I look at it, if you look at a 3-year doctoral of physical therapy program, their credits, I think, are often around 120 or 130 credits, which, hey, that's great. They work really hard. That's a difficult program over 3 years. When we looked at the credit equivalents for my MD, it was 320. And so the doctoral PT program is about 40% maybe in 3 years of what a 4-year MD is. And we have such a challenging time during our medical training that if you condense it further, what I worry is you'll take already strained medical graduates into intern and subsequent residency years, and you'll have this graduated time and work compression that could be increasingly detrimental. I think our medical trainees are already suffering under time compression. Whereas through some back of the napkin math, if you simply had Congress do something and just open up funding for more residency slots that were important, we have plenty of funding compared to what our budget covers, it would be a rounding error to increase the residency spots 20%. And then if you had reduced barriers for quality international medical graduates that we could recruit, just by those two things, not through empowering our PA colleagues or increasing production of nurse practitioners or alternative health professionals, or through expanding the scope of non-physician clinicians, if just through those two things, just through increasing our currently available bandwidth and enticing people to support that. And then if you know truncation in medical school, I think the hard part for me is that if you want a medical clinician that had expedited training, I think PAs are fantastic. I'm a huge PA advocate. If you want the person that is the most extensively trained, you want a physician. And so I think if we can increase the capacity of our existing pipeline, we can prevent compressing our trainees further and continue to support maintaining the standard for what is really the highest standard of medical education. So for me, rather than compromising medical training, I would say like increase capacity. And for my fourth year, it was kind of interesting. When I went through my third year of clerkships, I would get like a high pass, honors, high pass, high pass, high pass, honors, high pass. And then I went to my fourth year, and then I got honors, 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 honors. And the extra time and counseling that I got, to rather than be like an eager to please third year medical student, but to be relaxed and appreciate the experience as a fourth year medical student, gave me some huge benefits going into intern year. And I think instead of compromising or truncating medical training, man, if you had to go straight from a compressed medical education where we're already training 7,000 hours in 4 years and go straight into residency where residents are given like no benefits and not even a living wage and strained even further, I think we could increase the physician supply without compromising duration, interestingly.
Fascinating. I love that answer. Next, true or false? Pediatric cardiology fellowship is harder than adult cardiology fellowship.
Ooh, okay. So I'm really good friends with Kendra Kunitz, so I'll call the business. And I think I will say false, except it is misunderstood how rigorous pediatric training is. So pediatric residency, comparing pediatric residency, I'll say peds residency is harder than internal medicine residency. I will fight anyone that wants to fight me on that. Pediatric cardiology versus internal medicine, the burden of disease that they get is substantial. And they do some complex work, but I'll tease my adult cardiology or cardiology colleagues as working through STEMI, NSTEMI, AFib, amyloidosis, or HFpEF, FREF, and then they just repeat that cycle. Whereas if you are a pediatric cardiology fellow that is working a 36-hour shift and you just admitted a failing Fontan and got a new diagnosis, severe Epstein's, and you have a TET that's failing, and you just got a heart transplant patient that's in rejection, and then you have a post-op that tanked, and so they got their chest open and they see ICU, and now you're bailing them onto ECMO, all within an 8-hour overnight period in the middle of a 36-hour shift. I don't think anyone understands how rigorous, how just brutally rigorous our fellowship experience was.
Spicy takes. I love it. Well, so if you say peds is harder than internal medicine, as a med peds physician, I'm very curious, where does med peds fit into that spectrum?
Yeah, so then you see us and you race. So that's tough because you guys take on both at the same time. So maybe you're the triathlete.
Oh, wow. Maybe we have the highest predilection of endurance athletes. Maybe I'm in the minority.
That could be it. Yeah.
That's funny. Well, that sounds like a good study somebody out there should do. All right, next, true or false? Doctors of previous generations worked harder than those doctors today.
What I just rattled off, right? If you had this Epstein's patient, failing Fontan, ECMO, heart transplant, they would have had Epstein's, but they didn't have heart transplants, they didn't have ECMO, they didn't have complex echo, they didn't have the complexity of the caths or CC surgery procedures we did, they didn't have staged surgical palliation. So what I would kind of push back on is I always struggled with having such a rigorous schedule and work, and then almost having it be undercut by more senior physicians say that what we were doing was easier. And what I really compared to it was, even if they worked long hours, and I still worked over 100-hour weeks for, like, more than 5 weeks in a row. It was tough, and we were on call every third or fourth night. It could be a 36-hour shift. There were ways to still work rigorous hours. um, it's like we were still working 100-hour weeks, and they thought they had it harder, that they were doing 120-hour weeks. But I thought it was harder to run all out 100 miles than to jog 120. And so I think medicine's only getting more complex. And if you have ECMO and heart transplant and complex staged surgical palliations that you're managing in one shift, none of which existed when they were a fellow, I think the complexity and burden of disease and acuity of the disease, the variety of it, it's only getting harder. So I will never be an attending that tells my trainees that they have it easier than I did. If anything, it gets more complex, and I think they're more strained by the work compression, even if the hours could be 80 hours instead of 100.
It's fascinating, right? It's like there's more to it, to your point, than just the total amount of time you actually spent physically in the hospital. Um, well, okay. Last true and false. True or false? LDL is the most important lab value a person can track to evaluate their heart health.
Fantastic. Oh, we could spend the entire hour on just this question. So interestingly, false. I would say it's the most misunderstood, or the one with the most misinformation. But what I see all the time is people will say, "Oh, LDL's not bad for you. It's inflammation that's bad for you." And then I'll say, that's like going to an Australian and being like, "Hey, great white sharks are completely fine. Like, my buddy was attacked by a crocodile. He wasn't anywhere near a great white shark. So great white sharks aren't bad for you." So all I say is, like, please let me teach you the data. Each of these individual things, if it's LDL, LP little a, triglyceride, insulin resistance, blood pressure, or inflammation through HSCRP, each of those can cause a heart attack on its own. Depending on how long you're exposed to it, or how high it is, or both, it can be worse for you. But each one of those risk factors is bad. Is one of them specifically the worst? No, I could make an argument that LP little a is comparable or worse, and then inflammation is worse. But guess what's even worse than inflammation? Inflammation and high LDL at the same time. And then I can show that in any JM study that shows exactly that. So most misinformation currently about a topic, LDL, but the worst one for you now.
All right. Here's our last question we ask every single guest. We get lots of information. Maybe you've never had more information than today, but the information doesn't always actually affect or change our opinion. So I'm very curious if there is anything, doesn't have to be in medicine, what is something that you have recently changed your opinion or mind about?
Everyone's affected by personal bias. And so the problem is, when I work through families and try to encourage more activity, I'll try to do what's most effective. And so then oftentimes it does come down to burning more calories. And many families would say that they go walking and that they're active outside, but they would just kind of walk at a slow pace on level ground. And it's so easy to consume an extra 300 calories and so hard to burn 300 calories by gentle walking, that I didn't think that walking would be enough. But I met a patient recently, this past year, who established care with me for the purpose of the weight loss medications, which I'm one of the physicians that can prescribe those in pediatrics. And so they were referred to me for the purpose of those medications. I said, we can definitely do those, but please work with me and let's get started on this foundation of lifestyle measures that will support it. See you back after X number of weeks or months, and then pull the trigger and go from there. So they said, great, sounds like a plan. We talked through resistance training and protein and diet, and kind of getting in the habit that the medicines could then accelerate the benefits of the lifestyle they had. She came back and she'd lost 30 pounds in 3 months. And I thought she'd taken the medicines without me. So I heard from my team and about this. I saw her body composition scan and her weight and her growth chart before I went to see her. So I went in, I'm all excited, and she's there with her dad. And I'm like, how'd you do this? Can please teach me? I want to see what was so effective for you. And they had said the most flattering thing. I posted about this because they said, you did this. I was like, what? They said, you believed in us. And she left that visit believing in herself that she could do it. And she walked every day for an hour for 3 months, every day, and crushed it. I'm going to hire her as my own coach for my own lifestyle measures. Just this amazing experience. And so there's my personal bias. Like, oh, we always have to do more, everything more. Oh, can I do a triathlon? Oh, can I do an Ironman? And oh, no, it's all about consistency, right? What's best for that person? What can they do most consistently? And now I am recommending walking all the time. But I kind of give powerful examples of, still not just for short durations on level ground, but longer if it's not at an incline or fast. So you still talk through the nuance, but my patients prove me wrong happily all the time.
Amazing. Dr. Weyhrauch, this has been awesome. Where can people find more of you online, more about you?
Thank you. Yeah, I would love to encounter anyone. I do my very best to engage. So I will find you in the comments on any given post. But my main platform has been Instagram, where it's my name, Derek Weyhrauch, like Weyhrauch the boat, but it's spelled the German spelling. So if you search Derek W and then MD, I come up on Instagram. That's my main page, but I'm also on TikTok, on Facebook, and then on YouTube. I'll be posting more long format educational videos on YouTube. So Instagram on YouTube will be the main places to find me. I try to get to as much interaction as I can on there.
Amazing. Well, thank you for being here, and thank you for all the work you do individually with families and patients, but also for communities as a whole with your platform. So amazing work, and appreciate your time here today.
My privilege. Thank you so much for the opportunity.
Thanks for joining us this episode, and you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening, and the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.